Hi, I'm Dr. Alison Van Dyke, a physician dual trained in cancer epidemiology and pathology, working in public health at the National Cancer Institute with the SEER Cancer Registry System. SEER stands for the Surveillance Epidemiology and End Results Cancer Registry System. Today, I hope to shed some light on COVID-19 and SARS-CoV-2, the virus that causes COVID-19, and associated laboratory testing. This is an ever-evolving field that changes rapidly on a daily basis. In this talk, I will be focusing on COVID-19 and SARS-CoV-2 testing, and we'll be touching on some population statistics and concepts like herd immunity. This detailed timeline is for your reference and outlines the key events in the COVID-19 pandemic. Briefly, China initially reported the outbreak to the World Health Organization in December 2019. By January 2020, the first cases in the US were identified among travelers returning from Wuhan, China. And by May 2020, testing had ramped up in the United States, as well as vaccine and treatment research development. Symptoms of COVID-19 include generalized aches, muscle aches and pains, and more commonly fever, fatigue, and respiratory symptoms such as dry cough, sputum production, and shortness of breath. A smaller proportion of patients experience gastrointestinal symptoms, and interestingly, loss of taste and smell have been reported to precede the onset of respiratory symptoms. As many of you know, the presentation in a patient with COVID-19 can range from no mild to mild symptoms to very severe shortness of breath, high fever, and cough, requiring hospitalization and even being put on a ventilator and then death. One question people often face is, are my symptoms allergies, influenza, the common cold, or COVID-19? This table here is for your reference, but important distinctions are the wide variability of symptoms and their duration for COVID-19 patients when and if they first appear. What makes SARS-CoV-2 so insidious is that while influenza strikes suddenly, SARS-CoV-2 is a stealth virus with symptoms that present as long as 14 days after exposure to the virus, and some individuals remain asymptomatic. The key in this disease is the variability between people in their disease presentation. So SARS-CoV-2 is a coronavirus just like the common cold. And like the common cold, it is a person's inflammatory response to the virus that causes so many symptoms. So while some people experience mild symptoms, others have more severe disease. In COVID-19, some patients become critically ill, requiring support from a ventilator and even die. So unlike the common cold, some of these patients become critically ill, requiring support, life support. On the left of this figure, which shows the biology of the underlying variability in symptoms among COVID-19 patients, you see what happens in an asymptomatic individual with mild or somebody with mild presentation of COVID-19. On the right side, we see what happens in a person with a severe clinical presentation showing a hyperinflammatory response that involves cytokine storm and release of chemokines. These are chemical messengers of the immune system, and that this results in multi-organ system damage, including COVID-19 patients often are in a procoagulant state, which means that they tend to form blood clots. And all this combined results in end organ damage to lungs, kidneys, the heart, liver, and spleen. In addition, some patients present with a rash and from blood vessel inflammation or vasculitis. And some patients, as we mentioned, form blood clots and in many organs and even lose digits or limbs. I'm going to focus on lung disease and COVID-19 as that is the organ most critically impacted. In order to understand COVID-19 lung disease, a person needs to understand normal lung physiology. The lungs are a branching tree of airways that end in air sacs instead of leaves. The picture on the right shows what those air sacs look like under the microscope. And featured in this circle are the plump type 2 lung cells that are what get infected with the SARS-CoV-2 virus. There's a wide spectrum of lung pathology findings in COVID-19 patients. These are pictures taken from published reports of autopsy cases of deceased COVID-19 patients. And while the most common presentation clinically is acute respiratory distress syndrome, which is seen on pathology as diffuse alveolar damage, we see other presentations as well, like blood clot formation and inflammation of the vessels in the lungs. So these, in acute DAD or diffuse alveolar damage, these patients, what we see is that the smallest vessels in the lungs, the capillaries, become leaky, and their air sacs that we showed on that previous slide fill with fluid, and the lung cells lining those air sacs slough off. And with time, there can be fibrosis and scarring as well. SARS-CoV-2 stands for Severe Acute Respiratory Syndrome Coronavirus 2. SARS-CoV-2 is an RNA virus surrounded by an envelope that has proteins on it. The teeth-like proteins depicted in the circle are the spike proteins that cause the virus to bind to and enter lung cells lining those air sacs. There's also a nucleic capsid protein, which looks like in this figure like a blue string of pearls that wraps around the RNA. Thus far, there are 7 known coronaviruses. 4 caused the common cold and were discovered in 1966 and cause mild disease. The other 2, SARS and MERS, or Middle East Respiratory Syndrome, which was discovered in 2012 in Saudi Arabia. And this can cause, like SARS and COVID-19, severe respiratory disease that can be fatal. And what's common to all of these coronaviruses is that their reservoir and intermediate host include bats, cats, and rodents, and in MERS, camels. As of July 20th, there were over 14 million confirmed COVID-19 cases worldwide, with over 603,000 deaths. And what you see in gold here are the numbers of cases over time as they increase in North America, South America, and Latin America combined. Focusing on COVID-19 in the US, as of yesterday, there were over 30.7 million COVID-19 cases, resulting in over 140,000 deaths in the US alone. These numbers include confirmed and probable cases, and they likely underestimate the actual number of cases as people can be asymptomatic. One of the tragic aspects of this pandemic in the United States is the marked disparities, or are the marked disparities by racial ethnic subpopulation. On the left, we see the proportion of the US population comprised by each racial and ethnic group according to the census data released on July 1st, 2019. On the right, we see the breakdown in cases by racial ethnic group. And while non-Hispanic whites comprise 60% of the US population, they comprise less than 40% of COVID-19 cases in the United States. In contrast, the Hispanic or Latinx population represents about 18% of the US population and accounts for almost a third of the COVID-19 cases in the United States. Similarly, this figure shows the distribution of racial ethnic group among COVID-19 related deaths. It really underscores the need for equal access to testing, care, and prevention methods, especially among non-Hispanic Blacks, who comprise 13% of the US population and 22% of the COVID-related deaths. Looking at these trends in the United States, these projections are from the University of Washington model using the data from the Johns Hopkins Data Repository. Depicted are the daily case counts. In brown, you see the projected number of infections. In red, the number of infections if public health restrictions are eased, and green infection dotted line shows the projected number of infections if we all wear a face mask. So what it really underscores is how critical following the public health guidelines set forth by the CDC really are. And not shown here are the total projected deaths by November 1st. The current projection is that in the United States, there will be 224,000 deaths by November 1st. If mandates are eased, that actually goes up to 241,000 deaths. In contrast, if we all wear a face mask, a simple method of preventing spread of the disease, 183,000 deaths will have occurred by November 1st. So quite a big marked decrease in the impact of this disease in this country. In order to understand how infectious SARS-CoV-2 is and what to do about it, we need to understand herd immunity, basic reproductive number, and herd immunity thresholds. So herd immunity is when there is protection of vulnerable populations through widespread immunity in the population. And there are two routes of achieving immunity. One through native immunity through exposure to a virus and via widespread vaccination. So this figure depicts the spread at the top in a naive population and spread through a population when herd immunity has been achieved at the bottom. So in blue, you see the figures are susceptible people, red depict infected people, and orange depict people who have recovered and are immune. At the top of the figure shows a naive population. One infected person goes on to infect four other people who go on to infect people themselves and spread throughout the population. In the bottom figure, where herd immunity is achieved, the infected individual only transmits the virus to one person, and the rest of transmissions do not lead to disease because the other people mount antibody responses to the virus and clear the virus, and therefore they do not go on to infect other people. As such, vulnerable people who can't get vaccinated because of their health conditions, for example, people who have autoimmune diseases or who are on immunosuppressants or who have cancer, these vulnerable people are then protected when herd immunity is achieved. So because SARS-CoV-2 can lead to such severe disease and death, we really need to focus on slowing the rate of transmission via testing and following precautions like wearing face masks, good hand hygiene, and social distancing. Next, let's compare herd immunity thresholds for different viral infections. So comparative herd immunity thresholds are reached when the proportion of susceptible people in a population is below the threshold for transmission. So depicted on the right here are viruses that require vaccination to eradicate and or control them. For example, rubella, approximately 70% of the population needs to be immune to protect susceptible people or vulnerable people in the population. For H1N1 influenza virus, on average, 30% of the population needs to be immune to confer immunity to H1N1 to the rest of the population. That figure more than approximately doubles for SARS-CoV-2. So that estimate is approximately 60% on average. One comparison often made is between COVID-19 and influenza. Both are spread via the same routes and both cause respiratory disease. However, COVID-19 is associated with much more frequently multi-organ system failure and death. There are differences between influenza and COVID-19 in the percent of severe disease and incubation period. So the incubation period is the time between infection to symptoms. And in influenza, it's it's a much shorter period of time than in COVID-19. So influenza often causes rapid onset of symptoms when a person is shedding virus. In contrast, COVID-19 patients can either be asymptomatic or um, do not appear to have symptoms until 4 to 5 days on average, and that figure can be close to up to 2 weeks. So while the flu spreads faster than SARS-CoV-2, COVID-19 leads to more severe disease and can spread undetected because of the longer incubation period. The other important thing to keep in mind is the crude mortality ratio. So for COVID-19, that's been estimated to be anywhere from 1 to 4%. In influenza virus, it's 0.1%. The true crude mortality ratio for influenza virus is unknown as it's not a reportable disease. To understand herd immunity, it's important to understand R0, or the basic reproductive number. It's the average number of secondary infections from a single infectious individual in a completely susceptible population. And for SARS-CoV-2, that can be anywhere from 2.2 to 5.7. If we assume the upper limit of this range, then it will take approximately 80% of the population needs to be immune to confer immunity on a population level and thus protect vulnerable people within that population. When thinking about SARS-CoV-2 testing, there are 6 basic considerations. What tests should be conducted? Who should be tested? What specimens should be collected? How are the test results interpreted? And what are the recommended actions by test type and result? I will try to answer some of these questions. As of yesterday, over 48 million tests have been performed in the United States, with over 4.5 million positive test results. Furthermore, 37 of the United States, 37 states and territories only report diagnostic tests, and the rest report both viral diagnostic tests and antibody serology tests. The 3 different classes of a test indicate different things and have different purposes and different intended consequences. So the 2 main types of tests are antigen tests and antibody tests. We're going to first talk about antigen tests. The 2 types of antigen tests, which are detecting the virus, the foreign invader of the body, are the protein antigen tests, which we will not be discussing today as these tests often have sensitivity issues. We will be focusing on the gold standard test for our viral RNA, which is reverse transcriptase polymerase chain reaction. And this is a diagnostic of an acute infection and considered the gold standard. The antibody test, in contrast, really indicate prior exposure to the virus or an infection. The viral antigen and nucleic acid tests are shown at the top of this figure, and the antibodies are shown at the bottom of this figure. So for the viral RNA detection methods, first, a swab is made of the nasopharynx, the nasal, and the oropharynx, and then the RNA is extracted from that specimen. There are lots of copies made after converting that RNA to DNA. And it's really the detection of that virus and how many copies you see of it that determine if somebody has a positive nucleic acid test or a negative test. In contrast, an antibody test or a serology test is performed on a blood sample. And that blood sample is used to extract um, the serum and then expose the specimen to SARS-CoV-2 specific antigens, as well as antibodies that change colors if in the presence of if you have those antibodies to the SARS-CoV-2 virus. This slide here is for your reference and compares the pros and cons of each type of test. On the right is the viral RNA antigen detection test, which is the gold standard, as we mentioned, and indicates acute infection. And however, it does take time to get those results. On the left two tests are the two types of antibody tests, the rapid serology test, which do have accuracy issues. There are also other, as I mentioned, antigen tests that pick up the proteins, the viral proteins, specifically the spike protein and the nucleocapsid protein that we are not discussing today. Who should be tested by diagnostic tests has been outlined by the CDC. So for diagnosis of acute infection, it's the nucleic acid, viral nucleic acid test that should be performed. For diagnosis of acute infection, the prioritization for viral testing is for persons with COVID-19 signs symptoms, healthcare professionals even with mild signs or symptoms, all contacts of confirmed cases, neonates born to mothers with COVID-19, and individuals in high-risk settings, including expanded contacts in high-risk settings and asymptomatic individuals in high-risk settings. And what constitutes a high-risk setting is listed on the right of this slide. What will be critical for cancer patients and other outpatient patients getting outpatient procedures is that the CDC recommends testing patients prior to and post a procedure and prior to and post admission to a facility with or without symptoms. Antibody test is not for diagnosing an acute infection. It can be used in combination with viral RNA testing by RT-PCR for patients presenting late in the infection. And an antibody test does not determine immunity to SARS-CoV-2 at this time because it's not known if antibodies confer long-lasting immunity to SARS-CoV-2. In addition, patients suspected of post-infectious syndrome can be tested with an antibody test. And then antibody tests should also be done on a population scale to understand infection transmission dynamics in the population. What specimen to is collected will impact the likelihood of an error. So shown on the right are the detection rates for diagnostic testing of COVID-19 among COVID-19 patients by this type of specimens tested. So you can see a wide range in detection rates, some as high as 90% or greater than 90%, so for saliva and sputum, And it's really the combination of nasopharyngeal tests or swabs and oropharyngeal swab specimens that have the higher detection rate. This figure summarizes the temporal relationships between infection, appearance of symptoms, detection of viral RNA by PCR, and antibody detection. So the solid lines here reflect RNA detection, and the different line colors reflect different specimen sources or specimen types that were collected. The dotted lines reflect antibody detection. So in purple, dotted line is for IgM antibodies that usually appear first in response to an infection. And green dotted line is for IgG antibodies, and it's the IgG antibodies to the spike proteins on the SARS-CoV-2 viral envelope that are thought to be neutralizing for the virus. What you can see is that SARS-CoV-2 symptoms can appear as late as 2 weeks after the initial infection, and it's between 1 and 2 weeks after an infection that viral RNA levels increase with a peak of detection around the time of onset of symptoms. It is also possible for a viral RNA test to be negative if performed early after an infection and before symptom onset. It is also possible for a test to be negative for diagnostic RNA test, but positive for antibodies on serology if a person presents late after symptom onset. So how do we interpret these tests? And it's really important to understand testing errors and testing accuracy before we would cover this, how to interpret those tests and what actions should be taken. So there are two types of errors: false positives, saying that there's a disease when there is none, and false negatives, saying that there is no disease when there is disease. It's really for the purposes of SARS-CoV-2 and COVID-19, it's the false negatives that are the most worrisome. So an illustration of this is on the next several slides. So if 100 people are at risk of COVID-19 and 80 of those people have COVID and 20 of them do not, so the 80 who have COVID-19 are depicted in black figures here, and the 20 people who do not have COVID-19 are depicted in gray. So all of them are tested, and 57 of them depicted in blue have a positive test result, and 43 of them in green have a negative test result. So what does this mean in terms of test errors, interpretation, and consequences? So as we can see, in blue, the 56 people who tested positive and had COVID-19 were appropriately told to self-isolate. In addition, the 19 people who tested negative and told that they do not have COVID-19 or do not have COVID-19 and were tested negative, they were told that they do not need to self-isolate and are safe to go about with their daily lives without infecting more people. It's really these testing errors that we're concerned about. And while there's only one person figured in the red figure here who had a false positive test and was told to isolate when it would have been safe for them to have gone out and about their daily lives. It's really these people in orange or yellow where they tested negative, but they had COVID-19. And so these people were told they do not need to self-isolate, and they went on to potentially infect more people. So there are actions recommended by the CDC based on the testing type and result. So if you have a viral positive test, you most likely have a current infection and you should self-isolate and follow CDC guidance. If that viral test is negative, you most likely do not have a current infection. You should monitor for symptoms and seek medical advice as needed. As for an antibody test that tests positive, you likely have had the infection and you should follow CDC guidance. If you are negative on antibody tests, you likely never had an infection or you have not yet developed antibodies to SARS-CoV-2 yet, and you can still get COVID-19. If you have both an antibody test and a viral nucleic acid test, those combinations have different guidelines. So for people who have viral positive and antibody positive tests, they most likely have a current infection. They should stay at home and follow CDC guidance. Similarly, someone with a viral positive test and an antibody negative test also similarly most likely have a current infection and they should stay at home and follow CDC guidance. If you have a negative viral test but a positive antibody test, you likely had an infection and recovered and should take precautions and retest if your provider or workplace deems necessary. And if you test negative on both viral and antibody tests, you likely never had an infection and should take precautions and retest as needed as a provider or workplace deems necessary. So really the take-home points are that we've covered that the understanding the test type and interpretation are really critical for understanding how to apply this to public health planning and for personal planning, and that prior exposure does not always confer long-lasting immunity so there's always the potential for reinfection, and that's uncertain at this point. And one of the most important things is because we do not have an effective vaccine available yet for the population, it is really critical to take precautionary measures to slow that transmission of the virus on a population scale to protect not only yourself, but those in proximity and the vulnerable people in a population until an effective vaccine is available. And those are the simple steps such as self-isolation if you're symptomatic, social distancing, exercising good hygiene, and wearing protective face coverings. So I hope you were able to understand a little more about the SARS-CoV-2 virus, viral testing, and also about the COVID-19 testing.